Morning, my name is Robin Clark. I'm the Medical Director for Quality for UCLA's Faculty Practice Group, and my CHQI presentation is entitled Engaging Faculty in Value-Based Improvement, Choosing Wisely. UCLA Health is composed of the UCLA Faculty Practice Group, the UCLA Medical Group, and the UCLA Hospital System. We have around 1,250 faculty physicians that are based within 18 academic departments. We are now implementing an enterprise-wide Epic-based electronic medical record. And through a concerted effort, the UCLA ACO has around 100,000 patients that are currently in some form of value-based arrangement. My CHQI project is aimed at laying the foundation for success as we move as a health system to provide more value-based care. Specifically, my CHQI project objectives are within the academic departments to develop the infrastructure for value-based improvement by, one, developing the faculty culture to discuss appropriate care and promote systematic improvement projects, and two, by developing our measurement system to track care pathways and feedback data to our faculty. There are three core components to building this value-based infrastructure at UCLA. The first is my faculty practice group team, composed of myself as the medical director, an assistant director who is a graduate student, and one or more data programmers. The second core component is our health systems data repository, which integrates clinical, administrative, and other types of data into a single warehouse. And the last crucial component is faculty involvement. And we currently have 46 faculty quality officers based within the academic departments. My CHQA project uses a standardized structured approach to integrate these three components, with the objectives that by the end of 2013, every department will have quality teams that are reviewing their performance, and will have automated data on quality measures that will be fed to those quality teams. I'm going to spend the presentation describing the standardized structured approach. The design of the engagement with the faculty has specifically been developed to be bottom-up and collaborative in nature. The first crucial step in this is that a faculty quality officer has been designated for each of the clinical departments and divisions. I have engaged these quality officers extensively through monthly group meetings and regular individual meetings with each and every one of the quality officers. I have found that they are eager for systematic data about their clinical practice. To develop these systematic data, I have asked them to define measures for underutilization, that is, not providing enough evidence-based services, and overutilization, that is, providing services beyond what is necessary or effective. In the process of developing these quality measures, I found that the quality officers initially focused on addressing underutilization. I believe this is likely related to that many validated national measures exist in this field, and they are used to being assessed in this manner. Therefore, they were easily able to elect departmental quality priorities for underutilization. In slight contrast, they were receptive but less experienced with addressing overutilization. Again, this is likely because there are fewer nationally validated quality measures for this. So consequently, my project needed an additional device to engage the quality officers and their quality teams in identifying overutilization. The additional device was the Choosing Wisely program that I will discuss in a few moments. But first, I wanted to illustrate how we are defining and implementing these quality measures. This is an example from the Department of Neurology and how they are addressing underutilization of screening for complications for multiple sclerosis patients. Using our standardized structured approach, the neurology quality officer has identified a population of interest, in this case, multiple sclerosis patients, and identified an outcome that meaningfully drives care for that population, in this case, urinary tract infections. My faculty practice group team then defines and programs the quality measure into our centralized data repository. We feed back data on urinary tract rate infections by patient characteristics, by provider, and by facility to the neurology quality team that use that information to describe the care pathway and the process steps by which a multiple sclerosis patient either gets or avoids a urinary tract infection. One of these important process steps is whether a patient received a bladder scan to screen for urinary retention. The use of these bladder scans is currently inconsistent. That's why this care pathway is not straight. However, by measuring the use of these bladder scans, targeting them to our at-risk multiple sclerosis patients, We can more reliably deliver them, we can straighten out this care pathway, and we can optimize our rates of urinary tract infections. We can also measure the downstream effects on hospitalization, sepsis, and mortality for these chronically ill patients. So in summary, with a few short steps, we're able to engage faculty and develop a measurement system that is actually designed by and for the clinicians that are going to use the data. That was an example of how we're developing measures for underutilization. And as I mentioned, we're using the Choosing Wisely program to help faculty address overutilization. The Choosing Wisely program is a national program spearheaded by the ABIM Foundation, which asks professional societies to identify 5 overused services within their field. There's been excellent participation in the Choosing Wisely program over the past year, and the main aim of the program is to encourage physician-patient discussions about care decisions. We're innovating and using these Choosing Wisely lists created by the professional societies to initiate UCLA faculty discussions about value of care. This is an example of how the Department of Pediatrics is using the Choosing Wisely list that was created by the American Academy of Pediatrics to address overutilization of imaging for pediatric head trauma. Again, using our structured approach, the pediatrics quality officer defined a population. Here, children who have experienced a low-impact head trauma, and an outcome of interest, which is the receipt of head CT by facility and by physician. My faculty practice group team then defines and internally programs that measure, feeds the data back to the pediatrics quality team who defines the care pathway. And one of the process steps along this care pathway is the use of decision instruments that guide the ordering process for whether a child needs a CT scan or not. These decision instruments are inconsistently used, and again, we have a non-straight pathway. However, by measuring the use of these instruments, feeding the data back to the pediatrics quality team, we can more reliably use these instruments, straighten out the care pathway, and optimize the use of CT scans for these children. We can also measure downstream to ensure that there are no adverse events and complete the full description of the care pathway. This slide displays the timeline and our progress to date of this CHQI project. Again, the 2 objectives were to develop our faculty and develop our measurement system over the course of the calendar year of 2013. These are the specific steps in this standardized approach that I've just illustrated through the examples from the departments of pediatrics and neurology. And in keeping with our aim to scale up this approach across the entire health system, all 37 divisions and departments within the health system are progressing through these various steps. And I'm happy to report that within a few short months, new quality teams have emerged. They're receiving data about their clinical practices, and they're starting to describe these care pathways. These pie charts display the progression from the left to right through these steps. So what I've described in this presentation through this project is a standardized approach for engaging faculty, for developing a measurement system, and for laying the foundation for value-based improvement. My preliminary observations from the project are that this approach has been broadly accepted, with the faculty embracing the program and voicing little concern about measurement, transparency, and accountability that are often associated with traditional quality improvement projects. Additionally, this approach is very scalable because the clinician engagement is isolated to just defining the measures, while the project support team handles all the technical aspects of programming and obtaining the data. Lastly, this approach is foundational for other UCLA goals of sustainably and effectively addressing over and underutilization as more data become available and becoming increasingly more successful in delivering high-value care. Again, thank you very much to Terry and to the Center for the support of this fellowship.